of the lovely team treating Mr. Ocian. It is a must to say I'm delighted to have Dr. Sergio with us physically. Thank you, Mr. Chairman. Lastly, I would like to thank Dr. Nasser Said for his kind invitations. Now, I'm really impressed with the way of treating Mr. Ocian, but actually I would like to go back for these pictures because I'm actually believe much in treating the local vein, whatever you do with a superficial and a deep system, but I believe much in treating the local vein around ulcers. It does make great difference in the rate of healing. Also, and on 1996, I have been in St. Thomas's Hospital working for Professor Kevin Banan. He used to do, I can't say aggressive technique, but he used to do shaving technique for this, the area, sorry, I don't know if you agree with me or with him. He removed all this is not working. I mean, he removed all the lipodermatosclerotic area, this unhealthy skin, quite deep to the bone. And he used a plastic knife deep to the periosteum, because the periosteum is quite highly vascular. And actually, I've seen many cases healing perfectly after a while of daily dressing. And lastly, you put half-thickness skin graft. Okay, healing nicely, but it may be a bit ugly. Then I moved to St. George's on 1998 with Professor Robert Taylor. He used the same technique, but not aggressive, down to the periosteum. He just removes all unhealthy fibrous tissue until getting a healthy granulation tissue. But he may add something. He do multiple perforation to the tibia. Hoping the best, this may increase the blood supply to this ischemic area. And actually, so this 2 points, I would like to hear from you the feedback, especially from the chairperson. Thank you very much. Thank you, Dr. Ayman, for letting me one of the lovely team treating Mr. Ocian. I don't know Mr. Ocian who is. You know?
George Clooney.
I know.
Thank you, Dr. Nasser. I think we have a few minutes for discussion, our guests online. Now, as you all see, we have 8 giants trying to treat Mr. Ocian. Dr. Khalid paved the way by his diagnostic map. Then Erica wants to preserve the great softness vein, while Lowell wants to ablate the vein. I put some consideration. Please think quite about lateral marginal vein before you are going to do anything. We shift to another issue for treating the ulcer and sclerotherapy with local treatment. And Sergio wants to put a very important point for compression must be long-lasting. Now, I think we have our professors online. Are they? And I open the discussion. I will let Sergio will lead the discussion, and if you have question, let's talk to the giant.
And as we have giants also in the audience, I like to hear your feedback about ablative versus saphenous sparing in a case like this. For example, I think you did a great job, but I would need more information to really give an answer. For example, I would need to know if when you're talking about GSV incompetence, you're meaning just the saphenous arch, or are we assuming that also the terminal valve and the iliofemoral tract is incompetent? And also that anterior perforating where you were mentioning, I would actually focus on that and eventually look at above that treatment. So I would open also for the audience, if you want to give us your feedback, would you ablate everything? Would you do something tailored? Or also you guys, if you want to get in touch.
My question for my dear friend Khalid, for venous ulcer cases, do you usually routinely do ankle brachial index?
According to the presentation of the patient, if he has a suspicion of peripheral arterial disease, I think it's all the patient presented with a venous ulcer, you must do an ankle brachial index to exclude any arterial involvements. Because if you have any arterial problem, I think the decision will be different if you're treating only a venous patient having venous problems doing the ulcer. So you must, in every patient coming to you as a diagnostic person or diagnostic vascular diagnosis, to do a very simple ankle brachial index to exclude any major arterial involvement, even in compression. I think compression will be changing the decision of compression if you have an arterial pathology or arterial problem.
Okay. I have another question maybe for the all speakers, if you allow me to ask about treating the venous ulcer. Do you usually concentrate on the truncal vein or you just concentrate on the venous ulcer itself? Maybe I'll start with you, sir.
I would absolutely look at the whole hemodynamic picture. In the case that Ayman showed us, there is clearly a leaking point that is far above, for which there is, of course, the need of closing it. So I would focus, again, in the anterior perforator only if the terminal valve is competent at least at Valsalva or compression relaxation, because we publish in it both. In other case, I would treat also the terminal valve by a segmental shrinkage. But of course, I would focus on the distal perforator, and I think the interesting thing of the case is that we published that even if you have an outward diastolic flow of 0.5, it's really the net flow that you have to look at, because in a big percentage of cases, in reality, even if you have outward diastolic flow, the net flow is inward.
I agree with Sergio. We can treat the ulcer and treat the peri-ulcer veins with the compression, but the question, the recurrence. We can solve the problem temporarily, but still have a bomb. So I think we have to treat the bomb in addition to local care. And I have a question, I will direct the question to Erika. Conserving or preservation of the great saphenous vein, do you think it will last long, or it is a temporary stage, thinking you may prepare the patient for another step, or it will last long? Erika, are you still with us?
I take the mic. Yes, thank you for the question. I don't know why it's so difficult to read. I'm sorry, Ayman, I will attack you a little bit. There are so many studies comparing randomizedly stripping or ablation versus conservation, and we have demonstrated to have better long-lasting results with 3 Cochrane reviews. We have one meta-analysis done only by statistic people, not phlebologists. So they are, for them, it is the same which result, and they demonstrated wide out of the range that Shiva has the less complication and the less recurrences. So I don't tell you that I think, I know that the result is long lasting, because I do this since today, 26 years in this office. Today is the 26th birthday of this office. And I have still so many patients. I'm still ranked at one of the highest and best phlebologists in Germany. And I can only tell you, it brings less money than doing all the other things you do, but the result is long lasting. I can just tell you. And Sergio knows, he's sitting there.
I'd like to argue with Eric.
My first question, Dr. Sergio, is some other studies have demonstrated that a non-graduated elastic stocking by compression of the cuff area only could give you a good results by improving the fasciomuscular pump without the need for graduation. This is the first point. And the other thing is that if we are treating varicose veins or chronic venous disease, we should be emphasizing that we are palliating the patients because we are never curing the patient. The problem of the chronic venous disease is the capillary hypertension. So as Dr. Nasser said, some people would shave the area. This will give you you are buying a time because healing would occur by the wound care and the compression again to decrease the capillary hypertension. But you got to look at it as a global way. Do you have an obstruction in the iliofemoral region? So you got to stent it, open it. Or you just have a reflux of the superficial system and reflux of the perforators. If you have these refluxes without upstream obstruction, you can apply them freely and you will get very good results. But any measures that you do in the limb without relieving the obstruction, as Dr. Michael has pointed out, you are doing nothing to the patient health.
Two very interesting comments, because with the first one you are introducing the progressive compression concept, that is more pressure in the cuff. And this is absolutely good if we want to improve ejection fraction according to the hemodynamic studies that have been done. So usually, particularly in sport performances, they have been used and demonstrated their efficacy. But I tell you, we published another paper looking at the measurements of the sizes of the legs, the shape of the leg, so the impact of the shape on the leg on the graduated or progressive. And you will be, and I was astonished to notice that in reality you have quite a significant number of graduated compression exerting progressive compression. So this is related to that flight study I was also presenting about the flights on board, like of the planes, where we showed how complicated it is, the science behind compression. That is really a science. That's why we have to rely on certified products, because they were also showing that if you put the same interface pressure on the surface of the skin based on the subcutaneous thickness, you can have a variation of 50% of the subcutaneous pressure. So this is actually hampering the studies we have, because many studies are not even reporting the interface pressure that is there. So that's a call to action to dive into the science of compression, and that's why we are doing this Science Per App project, because the interesting thing of the aquatic environment is that indeed the Laplace law is not applied. So it's a model for the future compression. Regarding the second one, I just put another study that is pointing out how in C0S patients, so symptomatic C0, you have already a functional capillary density decrease, which means that the microcirculation already at C0S is hampered. And that's when what you said before is absolutely perfect. Compression as an inflammatory drug, as it was for the Lichtenberg presentation, where the inflammation of the endothelium is the trigger then of the evolution of the disease, becomes important. So I was looking at the audience and was thinking, how many of us are actually using spectacles? And we don't make a fuss about using spectacles along our life. And sooner or later, I think we all put spectacles on. So I think proper compression in the present and future could become the new spectacles in a population that is becoming older and older, more obese, for which we will have more and more venous hypertension.
May I interject here? Can you hear me?
Sure, please.
So from an Ocean 11 point of view, the movie lasts 2 hours. This patient is going to need a lot of treatment. I would throw him overboard. That would be the easiest method. You would cure his ulcer too. From a practical standpoint of view, I don't think we know all there is to know about ulcer healing. And we're jousting with windmills here. We're quoting literature, we're saying this, we're saying that. At the bottom line, I think that if we look at skin types, they're all different. And I really do believe in capillary hypertension. And I think that, is that the first thing that happens? Or is that a result of venous hypertension? So I think that when we look at the majority of contributions, if you have a deep venous obstruction, I would think that that's the major contribution to venous hypertension. And the second one for me would be axial reflux. The third would be perforators, and then the underlying venules, the ulcer. But we also know that deep venous reflux does play a role in this. So after everything is done and said, you know, we're looking at the last frontier of deep venous valves. So I really don't know the answer, and I can look at all the literature and the results that I have and claim good results in healing, but where are we? I think we really need to look at this a little bit better. And lastly, looking at that patient, it looks like venous to me, but we must remember that if you have a non-healing ulcer for a period of time, you must biopsy that to make sure it's not cancerous. Thank you for allowing me to talk.
Thank you, Lowell. I think I have a question for Dr. Cabrini, and let us see his comment. I would like to ask Dr. Cabrini, do you think when we are going to make varicose vein surgery, you prefer to use the standard Cabrini risk assessment score or modified risk assessment score for varicose veins?
So thank you very much. It's an honor to be here virtually, and I just want you to know I'm very fine, but flying causes blood clots, and especially I also have, because of my back issues, a May Theraner, but it's asymptomatic, so I'm trying to preserve my myself, and that's why I'm not traveling, but I'm doing fine, and I'm exercising every day. But I just want everybody who's reached out to me to know that I'm okay. I biked 110 miles last week, so I'm really okay. Now, I wanted to, before I talk about the Cabrini score, I'd like to just give an overview. This has been an unbelievable collection of fantastic data from around the world, and the Egyptian contributions here are enormous. And what you have learned and what you are practicing, and of course, Erica, all the talks were just great. And I remember in the old days, we used to put a stripper down the vein and attach it at the ankle and rip out those veins, and that's what we did with varicose veins. And we've come such a long way now, and I think it's very important. But there's something here that I see that needs to be connected, and that is that all of the zeal for intervention, all of the zeal for compression, and then the overlying melding of that with anticoagulation, they've all got to be joined, just like Virchow's triad, and they've all got to be done properly and interacting properly. And too many times individual specialists focus on what they're specializing in, and we need cross-fertilization between anticoagulation, thrombosis, intervention with these procedures, and compression, very important compression. And what about those people that can't wear stockings? Do you throw them away? Can you prescribe Velcro devices? We need to talk more about short stretch compression, and also the use of various modalities for application and removal of stockings. Since I found out I have May Theraner, I have my stockings on every day, all day. When I went swimming this summer, I just kept them on. But anyway, I have techniques to take them off and put them on that make it very easy. So I think all of this is important. Now, as to the Cabrini score in venous surgery and varicose vein ablation, it's not a simple answer, and we don't know the answer yet. We do know, though, that if you must do a thorough evaluation, and there's no risk assessment out there besides mine that even talks about obstetrical complications, preeclampsia, unplanned abortions, stillborn infants, retardation of the infant, placental insufficiency. If a patient has those symptoms, and you're dealing with a lot of women here when you treat them, you really have to screen them for any phospholipid antibody syndrome if they have the proper clinical indications. You never screen everybody. So that's one thing. The other thing is, and there was a great study out of Scandinavia on 183,000 patients showing that all members all the first, second, and third degree members of the family history are important for the patient who doesn't have a thrombosis history, but there is a history in the family. That's very important to uncover, and that information is often not gathered. And your common risk assessment tools, besides the very good United Kingdom tool, talk about thrombophilia. That's the wrong target. You need to talk about family history of thrombosis. So I urge everybody going forward to make sure that you're asking those questions, especially, I don't care what risk assessment you're using, but you must include the two big things in my mind, which in these venous patients that you're treating are the two recipes for disaster: obstetrical complications and family history of thrombosis. That having been said, I think that following up in the future, going forward, to keep track of your results, and just like the beautiful work that Kirill Lobostov and Thomas Urbanek did to show how the set points vary, we've got to do that for venous interventions. So I think that that's a very critical thing to do. And again, I'd like to thank you all for including me in this, and I'd like to, I can't wait to move forward with all of these issues. Great job, everyone.
Thank you, Joseph. I think for sake of time, I'd like, on behalf of Mr. Ocian, I would like to thank Professor Joseph Caprini, Erica Mendoza, Michael Littenberg, and my dear friends Lowell Kabnik. And I would like to thank dear co-chairperson, Professor Musad Sulaiman, Professor Saha, Professor Tam Fikri, and my dearest friend, Sergio Zancini, and my host, our host, the great Professor Nasser Said. Thank you, and have a very wonderful night.
Thank you, Dr. Ayman, for this very exciting sessions, but you didn't tell us how much Mr. Ocian paid for you. No, 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 calling for the, actually asking Dr. Assam to, he